So first of all, thanks very much for giving the opportunity to have this interview, and it's exciting to be able to do this with a new journal, a global journal that hopefully many people will read, so that we can spread the knowledge about these important therapies. So we started this gene therapy many years ago. It took us a long time to develop it. It was a long preclinical trajectory. And it was also difficult to get the regulatory path in place. But we have now a multinational, multi-center clinical trial, basically open to patients from all over the world. Although we have national context with many European countries, with countries in Asia and in Australia. And we're now recruiting patients. We have treated 5 patients thus far in this trial, and we aim for 10 patients in total. So we're halfway in the trial. And this disease is called SCID or SCID. It stands for Severe Combined Immunodeficiency. And it is a disease of the T lymphocyte. So these children or babies, it's really very small children, they do not have T cells, and therefore they don't have a good functioning immune system. And this is really a medical emergency. If you don't intervene aggressively, these babies will die before they reach their first year of life, and they will die of any infection. It could be a bacterial infection, a viral infection, a fungal infection, any simple antigen that normally people can handle very easily. They cannot handle it because they lack the immune system. And so the current treatment, what's being given is a bone marrow transplant from another donor. That can work very well if it's well matched, but often it's not well matched. So if you don't have a sibling donor, it becomes quite difficult. And then a lot of these children, and certainly for the type of SCID we work on, about a quarter to a third of the patients die very soon after the transplant because of graft versus host disease, which is a particular difficulty in this disease, where the newly developed immune system sees the host, so the patient, as foreign, so starts to reject the host. And that is very difficult and often fatal. Our gene therapy is using the stem cells from the patient, him or herself, and so we're correcting with gene therapy the missing gene. So in our case, we focus on a gene called RAG1, recombinase activating gene 1, and some other genes such as RAG2, and we have some others, but RAG1 is the one that we have in the clinic. And what we do is that we take the stem cells from these patients and then bring in with a lentiviral vector the missing gene, and then we give the corrected stem cells back to the patient, and then out of these corrected patients, a full immune system is developing. So in this case, in this disease, not only the T lymphocytes are absent, but also the B lymphocytes, so they also don't make antibodies. And after gene therapy, we now know that it is successful. We have patients that have been treated 3 years ago, and they have a fully functioning immune system now and are completely normal. So we think we have cured some of these patients for life. Yeah, so this is really a booming field. There are a lot of people working on hematopoietic stem cells, blood stem cells will be used with gene therapy, that combination. So you can use it for other diseases such as thalassemia or sickle cell disease. That's being done with all kind of different variation of how you bring in the gene, or if you do gene editing with CRISPR. But interestingly, and I think that's the most fascinating, is that this strategy can also be used for metabolic diseases. So diseases that affect the muscles, or even metabolic diseases that affect the brain. So neurodegenerative diseases, they can also be treated with this strategy. And that is because blood is everywhere, and there are some of these enzymes that are missing in muscles or in the brain are secreted, and therefore you actually can get treatment in the brain or in the muscles. And there is also exchange of immune cells with cells in the brain. So the microglia in the brain is actually also an immune cell, and there is exchange with the blood, and therefore you can actually, in a very efficient way, bring therapies into the brain. So I think that is really fascinating. It's not only blood-borne diseases in red blood cells or in platelets or in lymphocytes or other leukocytes, but also cells that are really outside of the normal blood system. And I think that makes this a very promising strategy for many diseases. Yeah, there are a couple of things that make this difficult. One is that it is a rare disease, so you need to identify the patients. And in many places in the world, there is newborn screening, but in a lot of places, it's not there. And when it's not there, you are usually late in identifying these patients, and then there is very little time to do things. So that makes it difficult, but in more and more places, this is seen, and in more places in the world, there are very good pediatricians who recognize this disease, so then you have time to do something. The second difficulty is that in general, this is expensive. So this is an expensive therapy. Um, and that makes it sometimes really difficult to bring it to patients. Of course, if you have a clinical trial, a lot of your costs are paid for, but eventually you want to bring this to the market. And then we see that with some of these gene therapies, they become really expensive in the range of millions of dollars for one treatment. That, of course, is in many countries not possible. So I think that's another problem that we need to tackle to see how we can offer this treatment in an affordable way. There are many ways of doing that. I think making some of the therapies cheaper from the laboratory side, we work on that. I think that is a possibility. Using better ways to make the vectors is a way, and eventually, I think non-viral ways to bring in like lipid nanoparticles or other ways are probably really important. What we have been able to tackle, and that is a problem that used to exist in the past, is there are a couple of centers where this therapy is being given. How do you bring this to the rest of the world? Well, we know how to do that now. So we've treated patients from Turkey and from Poland, and those patients stayed in their home country. So what was done is the blood was sent to us in the Netherlands, in Leiden, and we purified the stem cells, did the gene therapy, so the genetic modification and all the quality controls, the QC, and then we freeze the cells and we send it cryopreserved to a national center where then they can thaw it and give it to the patient. So in that way, you can send it, yeah, frozen anywhere in the world. And that problem we have tackled. So the problem of how you bring the therapy all over the world, that we have now. It's the first time in the world that's being done for a genetic disease. So that we have proven that you can do that. So now the thing is to make it cheaper and affordable and make sure that patients all over the world can benefit from this. That is not a medical problem, but more a financial and societal problem. And they can be more difficult sometimes. But I'm optimistic that we will actually get there in a few years. Yeah, I think if you like to do the research, then go for it. Make sure that you get a proper training in the lab. Go to wherever you want to go. If there is a good place you want to go in Singapore, go to Singapore. If you want to go to the United States or somewhere in Europe, follow your heart, go to the best centers. And for gene therapy, a lesson that I learned, if you want to develop gene therapy and bring it to the clinic, you have to talk to the patients. There are a lot of patient groups, patient advocacy groups. They are really important. They will tell you, okay, we want to have this kind of therapy. They also will tell you things like it doesn't have to be perfect. It will help us a lot if there is something better, because for many of these therapies, there is nothing. There is just a little bit of treating symptoms, but there is no real therapy. So anything that improves their life, they will love to have. And I think you will only learn that if you talk to the patient. So that was for me a whole new lesson that you really, of course, we always talk to the patients or the parents of the patients, but to involve them during the development in the laboratory preclinically is really very valuable and is I think an important lesson also for the young people to do that, because to me that wasn't obvious. I really needed to learn that over the years. Yeah, I think you're doing a couple of really good things. So you have a good editorial board. What is important is that you want to publish, so you want to attract initially some really good research papers and also review papers. Good review papers usually get cited a lot, so that helps the visibility of the journal and the impact factor. So that is, I think, something to be done. And then it's important that you're also at some point critical of the quality of the work. So you want to make sure that the work you publish is of high quality. And if there is work that is not so good, you should not hesitate to reject it, because um, it really helps the journal to have a good reputation, that if there's really poor work or poor science, that you do not publish that. I think those are the most important lessons to take for a new starting journal. But it's exciting to see this. It's a very exciting field, and I'm sure that we need many more new journals to be able to publish the work that is being done.